Well, I want to welcome everyone to today's session. We're excited to see so many participants. I know it's a really busy uh, period, especially end of year with schools and other things. And also just really wanted to thank our presenters for the amazing job that they've done in the 3 sessions and in today's final session. And really excited to have you. Reminding everyone, we were talking about this a minute earlier, that if you've missed any sessions or if you want to review any of the materials, that all of the webinars recordings are available on our website, which is telehealthrocks.org, as well as the PowerPoints. And we will compile a final resource list and send it out to all participants with the resources from all 4 of the sessions, as that will also be available on our website. So if you ever want to review anything from this series or any of our other series, or just even see what the other ECHO series are that we've had in this area, in the many areas that we've had ECHOs, please visit our website. And with that, I never remember who's kind of leading which session, so I'll hand it off to Emily, Ryan, or Dana, whoever wants to get us started today.
I can start. Thanks so much, Robert. And thank you to Robert and Christy and Evelyn and the whole telehealth ECHO team. We've been really appreciative of your support and letting us do this work. And also to all the participants, thank you so much for participating. And we appreciate having you. So just as an overall reminder of the agenda, or for those of you that haven't joined before, we'll start with just a brief introduction and disclosures, followed by a didactic presentation. Then we will have a participant present a case, followed by a group discussion. Next slide. So Dr. Ryan Smith, Dr. Dana Bakula, and myself are faculty for this ECHO. And again, we couldn't have done it without the support of the Telehealth Rocks ECHO team. So thank you. Next slide. We have nothing to disclose. Next slide. And just as a reminder, the information and recommendations involving clinical medicine that we discuss as part of this ECHO are based on evidence that's currently accepted within the medical profession, but should not be considered medical advice. Next slide. Following the session, we will be sending surveys immediately following, but also over the course of the next few months. We really appreciate your feedback so we can improve programming for the future. And the slides and the chat log will also be emailed to you after the session. Next slide. So without further ado, we'll get started, and today's didactic focuses on psychosocial supports for caring for children with medical complexity across all settings. Next slide. So by the end of this discussion today, we hope you can list the types of home care supports available, describe some basic financial supports, list supports for children with medical complexity and their families coping with chronic illness, and become familiar with psychosocial stressors for children with medical complexity and their families, and means to family empowerment. Next slide. So as an overview, first, just a word on the impact of caregivers. So caring for a child with medical complexity and maintaining all of the care in a home setting is a tremendous impact on families, both emotionally, financially, time investment. It impacts social lives, employment, really all aspects of life. So today we're going to touch on some of those components. I will discuss home care and financial supports. Dana will discuss coping and mental health supports, and Ryan will discuss ways to empower children with medical complexity and their families. Next slide. So, one more back. Can you go back to, yeah, perfect. So we'll start with Katie Beckett. So Katie is a child who used a ventilator, and she lived her first 3 years of life in the hospital. Despite having 2 working parents and insurance, insurance would not cover the cost of home nursing services that she required to live at home, even though that was cheaper than her hospital care. And if she left the hospital, she would no longer be eligible for Medicaid. So that set the stage in 1982 for some reform, and Ronald Reagan granted an exception that allowed her to move home but still receive her Medicaid coverage, including private duty nursing. So that became law with the Tax Equity and Fiscal Responsibility Act in 1982 that allows states to extend Medicaid to a child with disabilities. And it only considers the income of a child and not the family. Basically, I'll talk in some more detail about these different waivers through Medicaid. But prior to this change, children and adults and individuals with disabilities often lived in institutions, despite it being more expensive than care at home, but also that meant that they weren't able to live and participate in their community and in schools. And so this was a big change in the legislation that helped individuals with disability. Next slide. So home care for children can include a broad array of services. It can be nursing, physical, occupational, and speech language therapy, respiratory therapists, medical social workers, psychologists and mental health services, care from dietitians, home health or personal care aides, or private duty nursing. And this care does have an expense. It can often be a little bit unclear, kind of a black box then of how do I navigate this and who pays for it? Next slide. So just kind of as a very cursory overview, and special thanks to Patty Pepley, who will be joining us for our case discussion for her input on these slides. I want to touch on a few of the financial supports that enable home care for individuals with disabilities. So the kind of biggest bucket is Medicaid. So Medicaid is a state program, and I will go into more detail about waivers, but waivers allow individuals to get Medicaid services through non-financial requirements, early and periodic screening, diagnostic, and treatment, or EPSDT, that states provide healthcare services that are covered under federal Medicaid programs and found to be medically necessary, and that can include early intervention services, financial supports such as children and youth with special healthcare needs programs, supplemental security income, ABLE accounts, and special needs trust, and then finally home health services, including private duty nursing and consumer-directed personal assistance programs. So I will provide a little more detail on each of these, but kind of if I instill one thing today about these, it's that families should contact their service support coordinator or insurance case manager to discuss and learn about the options for their child. Next slide. So for Medicaid, a lot of the policies, unfortunately, are made with aging adults in mind, right? And so that population of children with medical complexity is much smaller. They are really only about 6% of enrollees, but they're about 40% of expenditures. So it's a population that states are paying more attention to. And in order to get private duty nursing or some of these home care services that I mentioned, really an individual needs to have Medicaid. Most private insurances will not cover these home care services. And so Medicaid must be obtained even as a secondary insurance if a child's going to get private duty nursing, for example. And that also includes other services like durable medical equipment or respite care in some cases. So basically, the issue, though, is every state has different rules about how they define medical necessity for evaluation and treatment, and it gives the state some leeway in determining that and the scope of medical necessity. A lot of times DME coverage can be inadequate to meet the patient and family's needs or the child's needs. And so there's a lot of inconsistent provision of home services then across states. I will, in the resources too, be sure to give you guys some websites where you can kind of look up each state's information. Next slide. So special thanks to Patty for sharing this resource, and with her permission, we'll share this afterward as well. This is a roadmap and basically can help you aid a family in navigating through how they can get to Medicaid. And I know it's a busy slide. It's really to kind of demonstrate that there's many paths to Medicaid. And for children with disabilities or medical complexity, often the waiver programs are going to be one of the biggest ways that they get these services. So we'll provide this for you in more detail so you can review it as well and click on those links. Next slide. So waivers. So when we say waivers, most states have long-term care services and supports through Medicaid programs that waive one or more of the Medicaid rules in order to extend eligibility and services to children. So a lot of times that means that the care that states offer, since it's more affordable than living in an institution, then the care they provide must be more affordable than an institution. So a lot of times that's a benchmark that's used. Unfortunately, not all of the waiver programs, though, are automatic, and that means that they can have really long wait lists. We will put in the chat some links here to Missouri and Kansas waivers. So in the Kansas City area, certainly we see patients mostly in Missouri and Kansas, but kind of a wide variety of areas. And there's other state information available too. And I'll go into some more detail on the Kansas waivers. Next slide. So here's some examples of some individuals so you can think about what kind of waivers, because there's a lot of different kinds and it can be confusing for me as a provider, but especially for families to try to navigate. So again, I can't emphasize enough working with insurance case managers, support case managers, and social work can really help in this process. So for example, a 3-year-old with autism spectrum disorder would apply for the autism waiver in Kansas. A 16-year-old with trisomy 21 who is able to do things independence but may need assistance with job training, transportation, help with independent living skills, and meal prep and paying bills. He may also qualify for a waiver. A 6-month-old with cerebral palsy, seizure disorder, G-tube feeding, being released from the hospital with 2 working parents, may also qualify for waivers, especially to help with managing his care, seizure medications, and feeding. And then a 13-year-old with mild intellectual disabilities who has trouble running away from home, is physically aggressive to siblings when not getting her way, occasionally refuses to go to school, or even has had issues starting fires. So these are all examples of children that would benefit from additional home care services. Next slide. So the 3-year-old would apply for the autism waiver. The thing to know is that there are some waiting lists for that, but that could help her get things such as ABA, in-home therapy, speech therapy, and focusing on safety skills and personal care assistance as well. The young man with trisomy 21 would probably benefit from the IDD waiver. So this waiver can certainly help for things with job and independent living skills and making his own meals, but it also has a long wait list. The 6-month-old with cerebral palsy, epilepsy, and G-tube feeding would likely qualify for the TA waiver or the technology assistance waiver. So this waiver is probably the one that I see most commonly for children with medical complexity in Kansas. And it provides services often without a wait list for individuals age 0 to 21. That includes personal care assistance, health maintenance monitoring, even home modifications, and respite care, as well as technology assistance. And then finally, the 13-year-old with aggressive behaviors and elopement would likely qualify for a waiver such as the serious emotional disturbance waiver. And although it doesn't have the best name, it could provide wraparound services for individuals age 4 to 18 in Kansas.
And Emily, we had a question from Alice Young, and
Yeah.
I don't know if you know the answer, but and it looks like Pat Pepple answered it, that a person can only be on one waiver at a time.
Yes. Yeah. Thank you. Only one waiver at a time. And so my understanding is that in Missouri, there's people that can kind of help you through the process, but in Kansas, you may need to know kind of what waiver you're going to be applying for. And there's different ages. You'll note some are 0 to 18, some start at 4. So it's definitely useful to direct families to get guidance to learn about these programs and which ones they'd qualify for, because they're really only going to qualify for one if they qualify.
And I know you'll address it later, but a resource people may want to reach out to is their CDDO as they're
Yes,
working through the system.
definitely. Yes. Great. Next slide. In addition to waiver programs, there's other financial supports. And that includes supplemental security income. So not everybody realizes, but children with disabilities may qualify. The amount really varies from state to state. And families should really go to their local Social Security Administration office or the website to apply and find out more information. There is also children and youth with special needs programs that are provided through the state. My understanding is these are usually a payer of last resort. So if a child has a waiver, those are usually going to be the main resources utilized first. But if there's additional services above and beyond, that might be a resource. And so those links are on there. And I also included the resource that I have from the Beacon program where I work, where we have compiled a number of resources for children and their families in Missouri and Kansas. It includes the program that Robert just mentioned and links to resources by county as well that you can help direct families to. Next slide. Yes, and agree. Thank you, Judy. So another thing to think about, a lot of times Medicaid from a traditional route considers income. So we mentioned the waiver programs can kind of waive that eligibility requirement and look at things such as these medical issues that children can then qualify. But so one thing to think about is income can affect other public benefits. And so in order to save money for items that children need, the ABLE account or special needs trust can be used to help allow saving without endangering qualifying for those benefits. I'm by no means a financial counselor, so I definitely encourage families to discuss with a financial planner. But these are maybe some things that they may not have been aware of. You might be able to direct them to. Next slide. So finally, private duty nursing. I think a lot of times it seems like a child would qualify, but it's very complicated, the process, and it really, again, depends on Medicaid and state by state rules. Often there's a minimum, like 4 hours per shift. Technology needs, such as a tracheostomy, a child with a tracheostomy typically needs 24/7 supervision by a trained caregiver that's awake. And so that type of medical equipment usually would qualify for private duty nursing, but other medical equipment may not. It really varies. They also take into consideration cognitive status, behavioral issues, and what activities of daily living a child needs assistance for. Unfortunately, the current state of affairs that's been probably worsened by the pandemic is that even if a child qualifies for, let's say, 16 hours a day of private duty nursing, there's just not enough private duty nurses to go around. There's a home health national shortage. And so as a result, it's an opportunity for advocacy, but also during the COVID pandemic, there's been some new resources that have come out that I wanted to draw your attention to. Next slide. So waivers have, under the state of emergency, now had some additional changes that have taken place that have been authorized by the Secretary of Health and Human Services. So the first, and I have Missouri and Kansas highlighted on this slide, and we'll put these resource links so you can look them up in more detail as well, are approved Section 1135 waiver provisions, which basically they can include provider enrollment and licensing requirements, a speedier appeal and fair hearing process, and reporting oversight for some of these programs. But more specifically, in Missouri and Kansas and several other states, they're allowing for family caregivers or relatives to be paid as caregivers to really fill that gap if a private duty nurse is approved but isn't there or isn't available. And some other services through the 1915C waiver Appendix K provisions. So home delivered meals, additional supplies and appliances and technology can be involved. So my hope as a pediatrician who cares for these kids is that we can advocate for some of these things to continue even after the pandemic is over or these have expired. So this is just a cursory overview. Again, there's a lot more information, but I want to pass it on to Dana to talk some more about how to support caregivers.
Dr. Goodwin, I will say there was one chat from Leslie, one question from Leslie Belzer in the chat. Can a family more easily get a personal care assistant if a private duty nurse isn't available?
Yes, great question. So these COVID-19 emergency authorizations makes it a bit easier to get family members paid as a caregiver. There are also personal care assistant qualifications that a child may qualify for that, even if they don't qualify for a full private duty nurse who has more skilled nursing training. Great question. And Patty Pepley, feel free to elaborate if you have additional information, or anyone else who's participating in this session if you have additional info on that.
I know we've tried to advocate for a few families that haven't been able to get their private duty nursing hours filled to see if we could switch some of that to a PCA. And some families have said, yes, it would be helpful to have somebody to help with like at least bathing, you know, even if I have to be there to administer feeds or, you know, do some of the medical cares. But I think that unfortunately, it is almost just as hard to find PCAs as it is to find private duty nursing currently. So that's something that we have advocated for, but I don't think it's like any more successful. But there is some flexibility if a family says, well, that would work because we are at home and it would, you know, I can give meds or run feeds and that sort of thing, because a PCA cannot do some of that more medical stuff.
Yeah, I wanted to call out some resources that were mentioned in the chat. Also, Judy White talked about working with your health insurance care coordinator or Medicaid case manager to determine eligibility and enrollment for waiver programs. And Dr. Kathy Davis talked about families together, and at KU Medical Center, the Medical Legal Partnership Clinic as other resources that can help navigate the waiver process.
Great. Well, if we want to go to the next slide, we're going to switch gears a little bit and talk about behavioral health. And I also just want to give a thank you to Dr. Leslie Belzer, who is a guest expert today and gave some of her input as well on our behavioral health information that we'll share today. And first, just when I say behavioral health, what I mean is that's really a blanket term that includes mental health, but also things like behavioral difficulties, trauma responses, coping with adversity. And it's really a broad term that's inclusive of some of the things that we'll talk about today with children and families. So next slide. So I'm going to talk a little bit about child and family behavioral health, and we could talk for hours about this topic, so I'll try to give a very brief overview. What we know about children with medical complexity is that many children are quite resilient. You know, we've talked a lot about the challenges associated with having medical complexity and caring for children with medical complexity throughout our ECHO series, and even in some of the highlights that Dr. Goodwin has shared in these first set of slides. And so we know that they face many kind of challenges and barriers, but many of these children are quite resilient. However, we do know that children with medical complexity are at a much greater risk for having things like depressive, anxious, and post-traumatic stress symptoms, for having behavior problems, for having low self-esteem. We've also talked about in previous ECHO sessions how these children are at much higher risk for learning difficulties. And we know that children with learning difficulties are also at higher risk for things like low self-esteem and some of these other kind of behavioral health difficulties. So really these children are confronted with a number of things that can impact their coping with these difficult experiences. Next slide. And I want to talk a little bit more, like I said, about family behavioral health as well. And I want to give a little bit of context for why that is. And when we think about working with children, we think about the fact that children exist within a lot of different systems. So they exist within a home with family members, in schools, in neighborhoods, and in larger kind of ecological systems. And the systems that are most close to that child both influence the child the most, but are also the most affected when a child has medical complexity and by the stressors and strains that places. And so really thinking about family behavioral health is also really critical. Next slide. And so similarly, when we think about family behavioral health, many parents and families are also quite resilient. Again, they go through a lot of challenges, but these families really work hard and figure out ways to overcome them and express a lot of resilience. However, we do know that similarly, behavioral health difficulties are experienced at a much higher rate in families of children with medical complexity. So these parents are at higher risk for parenting stress, depressive, anxious, and post-traumatic stress symptoms. They're at risk for poorer family functioning. Siblings of children with medical complexity also experience behavioral health difficulties at higher rates than siblings of children without medical complexity. So again, we see that there are certainly some difficulties coping and some behavioral health difficulties among these family systems. Next slide. And above and beyond caring about these behavioral health implications in and of themselves, we also care a lot about behavioral health because it has downstream effects on other areas of a child's life. So when we think about child behavioral health concerns, we see that children with behavioral health concerns have more difficulties engaging in the learning and school environment. There are downstream effects on their own health through various pathways. When parents and families have behavioral health difficulties, that's associated with greater rates of child behavioral health concerns. Those things are very strongly linked. They impact parents' ability to complete important tasks, such as helping the child learn or helping with medication administration. They can also impact a family's ability to access basic needs such as safety, housing, supervision of their children, transportation, ability to work and get an income for their family. And so behavioral health is not only important in and of itself, but it also is really critical to lots of these other areas of child well-being that we care quite a bit about. Next slide. So I want to talk really briefly about some things that you all can do to help support child and family behavioral health. And first thinking about ways that each of us in our interactions with children with medical complexity can support behavioral health. The first being just working to meet that child's basic medical and educational needs. Again, especially many people attending this ECHO are in school settings, and just really working to meet those basic needs of children plays such a critical role in supporting their behavioral health. Being patient with children with medical complexity and knowing that they often kind of work and move at different paces than other children. Using coping strategies to manage your own distress when working with children with medical complexity so that you can be calm and present with them when they need you. Noticing signs of distress in children with medical complexity, whether that's mood, affect, behavior changes, pain, other kind of bodily function changes, all can be signs of distress. And then communicating that information to the family, communicating and collaborating about that, those signs of distress with the primary medical teams who work with those children. And then in your conversations with families about any concerns that you see, giving them hope, letting them know that there are people and opportunities that can help them, and making a plan for follow-up, letting them know that you'll be with them through the next steps and following up and working alongside them to help them get the help and support that they need with behavioral health difficulties. Next slide. And then ways that we can all support family behavioral health, first and foremost, includes recognizing the inherent challenges and strengths of a child and family. Again, really thinking about all of these big picture topics we've been talking about and how that can place a lot of strain on a family, but also seeing the ways that they are really strong and resilient and the many great things that they're accomplishing, and putting that all into perspective with the concerns that you see. And listening and validating those family experiences. Again, the best thing that you can do for a family is just hear them and be empathetic and be a person who is able to listen to them and hear their concerns. And then also being able to normalize those concerns and those experiences and let them know they're not alone. I hope that the information that we've provided throughout this ECHO series, but also about some of the commonalities of child and family behavioral health concerns, can help you to share back that information with families and let them know that their experiences are normal and they're not the only ones experiencing those. And then finally, asking permission to help problem solve with families. Again, we never want to assume that we know what's best or have authority over what happens next, but really want to partner with families and ask them if we can problem solve with them, how they can seek out additional support for anything that they need. Next slide. And then finally, if you have any families who potentially could benefit from behavioral health professional support, I just wanted to give you all a little bit more knowledge and information for your own toolboxes about what some of those things that behavioral health professionals can do to support families, which include things like behavioral parent training, where we educate parents about ways to engage in really positive parenting strategies, behavior management strategies, adaptive therapies that can work one-on-one with children to help address coping concerns in a way that is developmentally tailored for their cognitive functioning. Sometimes this includes work directly with parents to help them manage stress or engage in problem-solving training, as well as psychological evaluations and advocacy and support for families. So those are some of the big areas that behavioral health professionals can add that kind of extra support for families. And with that, I'm going to go ahead and turn it over to Dr. Smith, and you can advance on to the next slide.
Thanks. So we'll start out with the word cloud. We have a lot of great information from Dr. Goodwin and Dr. Bakula. But I will say this is challenging work, whether it's in the educational or medical setting, working with children with medical complexity. But I know having the chance to work with these families is the thing that keeps me doing this work. And so Robert just put a link in the chat to participate in this poll everywhere. But what words come to mind when people think about what it's like to be a parent of a child with medical complexity? Stress and stressful. How we deal with that stress, resilience, I agree. Stress seems to be a pretty popular comment. The unconditional love and the strength of the love and compassion is certainly one of those things that keeps me going in this work. Getting back to strength, growth. Stress and reaction to that stress with resilience, not surprisingly, are very heavily weighted. The self-care is what we'll talk about a little bit in the next few minutes, but is so critical for not just parents, but siblings and these children with medical complexity. Problem solvers. I think I saw that, or problem. Yeah, great. Yeah, I think the problem got truncated, but problem solvers are definitely accurate. Detectives, yeah. I try to wear my detective hat, but I am definitely far, far behind these parents and being able to get to the bottom as to what's going on. Need for control. This is one of the things that is difficult, like for all these families that that have children with medical complexity. They have a lot to navigate, and having a say in what's going on, being able to educate team members around them is really important. Definitely strong advocates. A number of my parents of CMCs actually work at our medical school and educate our medical students about patient care and patient and family-centered care. Great. I think this is great insight, and I think it's pretty well in line for what I expected for this word cloud. And so Christy, we'll send this out, but we can run back to the slides. Many thanks to everyone for participating. So on to the next slide. So part of this is a shameless plug for some research that Dr. Goodwin, myself, and collaborative between KU and Children's Mercy has done with complex care, and a repository led by Dr. Jeffrey Colvin. We're doing some studies looking at this repository of complex patients at Children's Mercy from a number of different perspectives, and we're looking specifically at family empowerment. But I think it fits into this need to advocate for our families, our patients, and think about what Dr. Bakula highlighted with this ecological model for behavioral intervention. There are all these different perspectives that, again, impact how a family, how a patient interacts with the health and educational system. So where we looked at a family empowerment scale, a standardized tool that has 3 domains. And again, they're pretty intuitive. This idea of the family unit, the service system, all the educational healthcare services that are provided in the greater community, and whether or not being engaged, being empowered, being skilled in these domains provide benefits in these challenges that children with medical complexity face. Transportation, financial stresses, and communication obstacles are primary barriers to care for such patients and for patients in general, but with complex medical conditions, many times these issues are amplified. When we think about care coordination, CMCs by definition have a number of team members across educational and health disciplines. Our CMC clinic helps facilitate broad interventions for evaluation and management. Sometimes this is writing on behalf of neuropsych testing, determining the need for clinical therapy services to complement those services that are provided at school. Or we'll have some patients that want to get a broad second opinion at institution, and we'll facilitate a multidisciplinary evaluation at another medical center. And all of those things take a lot of work from all the different team members to communicate and provide the appropriate documentation. But honestly, giving parents that information, providing them that skill, letting them know how to navigate their medical record and the care of their child is really critical in all of those kind of more challenging situations for care coordination. One comment that I will make, I don't think it's probably disagree with too many people. Healthcare in general is just very disorienting. And with high acute care utilization, and whether we like it or not, ER and urgent care providers may be less open to individualized care for children with medical complexities than what they see in other settings. The fact that these patients have a large number of subspecialists, there's a number of opportunities for less than optimal interactions with providers. And I would say in general, in my work, a lot of my time is consumed in kind of preparing my patients for specialty appointments, other clinical experiences out in the community, and trying to understand the best ways to get access and have real positive interactions with providers. Our study, which looked at a few hundred families, saw the most prominent impact on family empowerment with this interaction with providers. So you get families prepared, and they just do a better job interacting with providers and navigating the great complexities of our healthcare system. Next slide, please. So caring for a child with medical complexity is a full-time job for parents, even if they do happen to qualify for waiver program and having a PCA or a private duty nursing support. This can lead to burnout, depression. Dr. Bakula talked a little bit about some of those behavioral stresses that occur both within families and siblings. I know I'll mention one of my parents of a child with medical complexity that was struggling with depression, exacerbated by a pending divorce and subsequent financial difficulty. And this was in the midst of a hospitalization for this patient. And so we were able to ultimately, due to some instability and some challenges in the family, we extended that hospitalization, provided some resources to the family, and developed a plan moving forward to navigate these challenges. But in the clinical care and actual physical health of our patients, the stress that our parents feel is real. And so there's kind of some end-around respite care that we can provide. Those patients do qualify for waiver programs. There is some opportunities for more formal respite care, but as providers, as educators, we need to just be cognizant of this stress and figure out what we can do to kind of navigate these challenges. Dr. Goodwin has a number of great wellness resources, which are good for us as education providers, but also for families that can assist those with complexity, their siblings, parents, in trying to navigate these challenges. Again, the challenges are pretty broad. Finances, mental health burden, all of those come into it, and doing what we can to identify those things, provide resources, and understand when respite care is available and what we could do to provide a few hours, a day, some amount of time to kind of recover, and for everyone to build wellness, siblings, parents, guardians, and patients' medical complexity is pretty critical. Next slide, please. So this comes into understanding how we find joy and meaning in our lives. Those with disabilities may have limited functional capacity, but they have the same drives, the same interests, the same move to accomplish as much as they, to set goals and to reach those goals. And so one thing that I try to mention to my patients very early on in working with them are some of the opportunities to engage in the community, out in the world, with their medical condition. There's a great program called Hope Kids in the Metro that I think is slowly returning to more activities with the COVID pandemic. They have monthly visits to museums, concerts, sporting events, theater performances for children with cancer and medical complexity. Again, it's so important being able to take part in some of these activities, like going to a sporting event that we may take for granted, is really critical to our families, siblings, and our children with medical complexity. I'll also mention the camps. Disease-specific camps is usually what we end up seeing. I have a few patients with muscular dystrophy, and each year their calendars are really oriented to the muscular dystrophy camp, and that they've been going to for anywhere between 5 and 10 years. And again, like building that community, building those skills are really kind of critical in finding meaning in these patients' lives. And I'll make a plug for a movie. If you haven't seen it, I think it was robbed of the Oscar last Sunday, but Crip Camp highlights a camp in upstate New York that of young people with developmental disabilities. And it was interesting to follow some of these individuals through the disability rights movement and the incredible impact that they made in the ultimate passing of the ADA, the Americans with Disabilities Act. So if you haven't seen it, go to Netflix and check it out. Next slide, please. So kind of related to this idea of finding meaning, finding joy, and setting goals to achieve those priorities that you have is the discipline of palliative care. Many may confuse palliative care with hospice. That's a specific subset of palliative care that provides intensive support services for children with a prognosis estimated to be less than 6 months. But palliative care uses goal setting in varied domains, including functional capacity, to maximize quality of life and limit discomfort. I remember one family that I have that has a child with severe impairment from a stroke set a goal of just wanting to be able to say 10 or 20 words via the tracheostomy speaking valves. And when we have clear things, some of them may be reasonable, some of them may be reachable, but to set those goals and kind of have that path forward to get there can be really, really helpful. And letting parents and patients really drive those is also the things that are really important. I know as a physician, I always have the things that I want to push forward, but doing it in a patient-centered manner is really important. And the palliative care specialists are kind of experts at having that take place. And so where I worked, one place in Minnesota actually required palliative care consultation with any of their new patients. But I will say that both KU Pillars Clinic and Children's Mercy Beacon Clinic, we have palliative care providers that can kind of help navigate that process. Next slide. So here are a few of our key takeaways. Hopefully we're a little bit more familiar with how to connect families to financial and social services, as well as insurance supports. We understand just how important it is to recognize and communicate behavioral health concerns. And then ultimately, how do we empower patients and utilize the resources to achieve family empowerment? Next slide. Here's some of the resources. We'll send these slides out.
Really, as usual, we have amazing amounts of information and things to do during these sessions. I hope everyone has found them helpful. We will be sending out a post survey because we always want to do better. And also we want to find out what your needs are for further training and further information, and what else we can do to support all of your works in your local communities, especially with these medically complex patients. So I hate that this is our last one. It's been an amazing period of sessions and a great discussion. And we hope to see you guys again in one of our future sessions, and looking at even adapting and doing further work with this. We'll hit up Emily and Dana and Ryan and many of the people you've heard from during these sessions to do another series for us, because we think this has been really beneficial, and hopefully you found it as well. So I hope everyone has a great day. Thanks for staying a couple minutes late, and see you at our next echo.